What are the chronic illnesses that affect Americans most? Heart disease? Yep, they account for more than 1 in 3 deaths every year in the US. Or maybe diabetes? Over 38 million Americans are dealing with it and its serious complications. But today, we're here to talk about money, because each year, Americans shell out a ton of money just to help them get back on their feet. We're talking about $4.8 trillion. Most of spending covers hospital care and clinical services, but one of the fastest growing sectors is prescription drugs.
I'm on Rinvoq, which is an immunosuppressant, $6,431.21.
My son takes Keppra to manage his symptoms, ranges from $1,000 to $1,600 per month.
Over $700.
$100,000. Trikafta, and its list price is over $300,000 a year.
Here's another example. This is Humalog, a fast-acting insulin that manages blood sugar for millions of diabetic patients. In 2019, a cost comparison report showed private health insurers in the US spent a median price of $1,723 on Humalog, while its cost ranged from $32 in South Africa to $79 in Germany. So, what are the reasons behind the high drug cost in America? And can we fix it?
So our system is set up such that pharmaceutical companies, right, the folks that are making the drugs, have the most control and the most power when it comes to setting the prices that they want to receive.
This is Andrea Dukas. She has spent years advocating for accessible healthcare.
There's also just so many layers to our drug system, both in terms of production and financing, and at every step of the way, there are entities that sort of take a cut of the prices.
Due to limited government intervention, the healthcare system in America has grown so convoluted that it allows third parties to extract enormous profits. Enter the pharmacy benefit managers, or PBMs. In essence, PBMs are the middlemen who decide how much insurers should cover prescription drugs and how much pharmacies get reimbursed. But since these gatekeepers can demand rebates from drug manufacturers for their products to be covered by insurance plans, the higher the list prices, the more money they can rake in.
You are incentivized for starting prices to be high. But we don't know actually how often that's happening or how much they're making because there's no transparency into that at all.
According to an interim report published by the FTC in July, the top 3 PBMs in the US processed nearly 80% of prescriptions filled at pharmacies last year. At the same time, these PBMs are owned by the same groups that control the country's largest insurers and pharmacy chains.
Consolidation, really dramatic consolidation in the healthcare sector, vertical integration, is contributing to this too.
In September, the FTC filed antitrust lawsuits against the PBMs, alleging their chase the rebate strategy led to skyrocketing list prices of insulin for the past 2 decades.
But here in the US, people believe in a free market. And you know what is the most notorious idea you can introduce to a free market?
Price control.
Price controls.
So, now what is wrong when it comes to price regulation on drugs? But some countries have braved the waves and taken the plunge. You ready?
The UK's National Health Service is 75 years old.
Serving over 66 million people, the UK's universal healthcare system, the NHS, relies on what it calls the Pharmaceutical Price Regulation Scheme, or PPRS, to keep drug prices in check. Here's how it works. The PPRS is a voluntary agreement between the UK government and the nationwide coalition of pharmaceutical companies. This agreement puts a ceiling on how much the NHS can spend on branded medicines each year. If spending runs above the cap, any extra sales revenue from pharmaceutical companies has to be paid back to the government.
I know, kind of wild, right? And you can imagine how many negotiations it takes for both sides to agree on this cap.
The essential feature of the UK system is that the government reserves the right to say no.
This is Peter Maybar-Duke. He works with governments of all sizes on their medicine pricing legislation.
So they have a system by which they assess the benefits of a given drug at its price point compared to other similar drugs and decide whether it's reasonable. If it's not reasonable, they're not going to pay.
Meanwhile, PPRS is totally voluntary, but for the companies that choose to opt out, a statutory pricing control will be placed on their sales.
Now, what if a government believes it needs to take a step further to bring down drug costs? This next country has done it all.
Back in 1962, the government of India issued the drug price control orders. Over the years, the authority put more than 300 essential and life-saving medicines under strict price control, like those for allergies, seizures, and even Parkinson's disease.
The Indian government also takes a hands-off approach for the development of generic drugs, relying on competition to help drive prices down. It doesn't sound too bad, right? The government steps in to keep life-saving medicines affordable. Why not?
Price regulation has to be smart and has to be aware of market dynamics, including the cost of bringing a generic drug to market, for example. India caps prices at the average of what leading brand manufacturers charge for a given drug. It's possible, at least conceptually, for very low-cost drugs to have prices that are too low, that couldn't attract enough competitors to the market to keep a drug in adequate supply.
And that seems to be the case in India. Following a new price control order in 2013, researchers found the average sales of regulated medicines actually dropped, possibly because smaller drug makers struggle to stay afloat with lower profits, or many companies just shifted their marketing efforts to promote other higher margin but non-regulated medicines.
So, what have we learned so far? If a government leaves the drug pricing to the market, like the case in the US, patients could face excruciatingly high prices. But if it's from arms to market, it risks choking innovation, or worse, limiting public access to essential medicines. So, is the UK model the way to go, or is there a better solution out there?
I don't think there's an optimal system in effect anywhere in the world. Now, under the Inflation Reduction Act, we have Medicare price negotiation for the first time, which is starting to make a significant difference in US drug prices. Essentially, what we're trying to do with Medicare price negotiation is correct for the abuses of our very lax patent system. We have allowed those companies to overcharge us and maintain a monopoly longer than many would say was intended by Congress.
It's a very big deal. The outsized response to that program, which just this year negotiated the prices for 10 drugs, right, that'll go online in 2026, that generated so much pushback, so much I mean, that should tell you something about the potential of that program.
But now we're bracing for a new administration next year. At this point, it's unclear whether Donald Trump will stand behind the Medicare negotiation. But some Republican legislators have said they are ready to repeal the program using their majority in Congress. But if the price negotiation goes through, Medicare is expected to save patients about $1.5 billion in out-of-pocket costs starting in 2026.
There's nothing more dehumanizing than having a medication be available in theory, but not available because of the price tag. It is incredibly depressing to have to spend so much time fighting for what you really just deserve as a human who is existing.